Okay, so thank you all. We'll get started. Thank you for being here this morning. And I would like to thank you for the following sponsors for the talk today. The ACL Administration for Community Living, Catholic Charities of Hawaii, Kali Kuiki, and I'm my employer, University of Hawaii. So we have a lot of ground to cover today, but it's going to be broken into three sections. We're going to start with something that's a little bit sort of timely, which is, geriatric mental health, in this case, in the time of COVID-19. What are the impacts and, what do we need to look for? And followed by what we consider the three commonly encountered psychiatric presentations in older people, or known as the 3Ds of geriatric psychiatry, including delirium, depression, and dementia. In the second half of the talk, we're going to progress into, what are the typical dementia-related behavior, how to identify, how to de-escalate, and what are the possible role for medication treatment for severe symptoms like physical aggression. Okay, so we're going to go into the first part right now. Okay, so COVID-19 pandemic and mental health. So how has it been affecting us in the general population ever since it started more than a year ago? So in general, there are more and more studies now coming out regarding the impacts on mental health as a result of this illness. So in general, studies have shown that there are increased PTSD or post-traumatic stress symptoms and depression among COVID survivors. And also for those people that already have mental illnesses, depression, bipolar, schizophrenia, having to endure various types of COVID-related restriction actually have worsened the severity of their symptoms. And not only is COVID affecting the patients, it also has been affecting caregivers and healthcare workers in terms of increased depression, anxiety, trouble sleeping, and overall stress. And people that are much more susceptible to these kind of mental health consequences, including female gender, people that are poor health already, and also people with relatives are known to have COVID-19. So how do these COVID-related mental health complications affect our older population specifically? And so, in the beginning of the COVID pandemic, we start thinking about, well, because older people, they're the most, vulnerable to COVID-related hospitalizations, medical complications. They're probably going to be the most susceptible to the mental health issues as well, due to isolation, due to all these increased personal protection they have to wear, just so that they do not get sick. However, what is surprising is that studies so far have shown that older people are actually a lot more resilient to what we had talked about as mental health consequences during COVID. That they are actually enduring less symptoms of less psychiatric symptoms compared to people that are younger. And this is shown by this survey that was done maybe a few months into the pandemic, looking at prevalence of anxiety, depression, or combination, or any kind of trauma or PTSD related to COVID that is stratified by, for example, age group. And as you can see, people that are older actually are reporting less incidents of experiencing different types of anxiety or depressive symptoms. And also they tend to resort to less substance abuse or consider suicide as a result of COVID. So what are some of the causes for this? Why is it that older people are much more quote unquote resilient in this? Well, so a lot of speculations have been made, and in general, but the consensus is that as we get older, we just have more coping mechanisms in dealing with unexpected stress, surprises, making us more resilient. And also older people, I guess, we've been taught for much longer about following rules. So they're actually, there's not a lot less sort of questioning attitude about using the necessary prevention tactics, wearing your PPEs, avoiding going outside. And also what's even more important is as we get older, we value the quality of relationships. So if they're able to have regular visits or phone visits with a family member or with a couple of friends, that's able to help them to sustain them throughout the whole crisis. Whereas younger people, they value quantity. The more people I have, the more friends I have, more social contacts I have on Facebook, or other social media, then that sort of makes me more wholesome. But the fact is, all that had sort of deteriorated, that they're not able to have all that kind of physical interaction anymore. So therefore, younger people are a lot more susceptible. Okay, so even though we, even though even though the older people are less likely to have mental health, related symptoms as a result of COVID, we still need to assess them and monitor them to make sure they're doing okay during this pandemic. And so, which comes to, what are the ways of monitoring how they're doing? And this has been relegated to the use of telemedicine. So how are they doing with the telemedicine? Well, the picture here is not as rosy. Is that so? This is a study showing that when they survey older people that are older than 65 years of age, in terms of how ready are you to have a doctor's visit using telephone or using any kind of televideo or video equipment. And this shows that if 38% of people that are 65 years or older are having trouble seeing a doctor or have seeing their social workers or case managers via video visits. And even if there's like another one or two adult members of the household present, there's still a struggle with the video visits. And then the situation is a little bit better with a telephone. Maybe 20% and 16% with support still had trouble with being monitored and evaluated. So what are the reasons for this? So as we can all imagine, lacking experience with any kind of technology has been a significant barrier. And also physical disability. A lot of them just cannot hear, cannot see, making any kind of telemedicine visit that much more difficult. In my psychiatry practice, I'm having quite a few patients now that have not been evaluated face-to-face by a physician for over a year now. Because of COVID, they're afraid to go out, and also they could not interact with a physician more than just a simple phone call. Yeah. Okay. And also the severity of not able to be monitored by videos or even telephones, it worsens with age. So if we look at the percentage of people that are not able to do any kind of telemedicine follow-up, if you look at the older group, this is where the study showed that 72% of them, that's a very large majority of them, were not able to be monitored by telemedicine consistently. Okay. So in our clinic, we have done a lot of telemedicine visits, as much as we can. And I just want to share with you some of the tips, pitfalls that we have noticed throughout the year. And so before any telemedicine interview, you do want to make sure that whatever app you're using is as simple as possible, not requiring any kind of downloads. This is usually when the older person will get tripped. If you have to download the program, they cannot find where the download file is. They will not know how to load it or activate it. It just creates a lot of confusion. So my experience is, more the easier programs to use like FaceTime or Zoom have been pretty effective. And also, we have all become IT experts now. Just make sure we allow a lot of time for technical issues. One suggestion I would have is to try to imagine what the patients will be having to go through. What buttons will be available to them, so you can help to coach them through it. Okay. And then during the interview, you do want to minimize noise, distractions as much as possible. Make sure there are not, other residents or other clients around, so they're able to focus on the TV screen. And you do want to make sure that there are ways of having separate interviews. You don't want a person with dementia hovering in the background behind the shoulder of the caregiver, debating and contesting, everything the caregiver wanted to report to you. And also what we have noticed is, a lot of people cannot see or they cannot hear. So if they could read using the share function, which is what I've been using, you can, write out your questions and you can share the screen, writing out simple sentences to ask how they're doing. And, or if they just cannot hear at all or be able to see, we found it pretty useful to have the caregiver just to repeat the question, short questions for you. And that allows us to assess how they're doing as well. Okay. Okay, so now we're just going to jump right into, the 3Ds of geriatric psychiatry. Okay, so you hear, a lot of people hear about, these, what are the 3Ds of geriatric psychiatry and how do we differentiate, one from another? So this basically, so these are the 3Ds, delirium, depression, and dementia. And the fact that I have them staggered, delirium over depression, depression over dementia, is for a reason. And the reason for that is we do want to pick up delirium earlier, because it can be a medical emergency and it is reversible. Whereas dementia is something that is more long-standing, not as much medical emergency. So we would want to look for those after ensuring that they're not delirious or they don't have a depression. And if I put them on this, axis here, a medical emergency. So because delirium is usually somebody who is infectious or taking medication they're just not able to tolerate, you do want to explore that first. And not only is it a medical emergency, it can also reverse it. So you can, they have a urinary tract infection, you could treat it with your own medication. That's giving them a lot of side effects, making them confused. You can just stop it. So whereas depression, yeah, there is some medical urgency, especially if they're, having thoughts about not wanting to live. And you can reverse it, but it takes a little bit longer than delirium. It takes treatment with medications or psychotherapy. And once I'm sure that they're not delirious or they're not acutely depressed, then we can focus on treating dementia-related behavior. This is, involving a much longer working relationship, with facilities or caregivers in terms of using or not using medications or employing other types of non-pharmacological techniques. Okay, so let's just kind of go through each of these one at a time. Okay, so we start delirium. So this is pretty straightforward. So delirium is, usually when someone is, out of the blue, within a few days, a caregiver can notice a significant change in behavior. Usually the hallmarks of people that are delirious will be their poor attention. Sometimes they're able to, and it fluctuates. So that's also the hallmark, fluctuation or changing levels. Sometimes they're able to listen to you, sometimes they can't. It's completely unpredictable. They're confused sometimes, or confused, not confused other times. They seem to be very sleepy, but other times they seem to be alert. And it's like a roller coaster. You have no idea what to predict, from like 1 minute to the next. And they're also psychotic. They're usually visual hallucinations and paranoia. So what are the usual causes of delirium? When, this is, constellation of behavioral symptoms, they're pretty acute, just came out of nowhere. Well, usually it's due to a medical illness. In people that are older, we're often looking at very, very frequently urinary tract infection or pneumonia, heart failure, or stroke. I just had a patient this morning who went to the emergency room because she indeed had this acute onset of psychosis. And they're hoping for a psychiatric admission, but gladly, in the emergency room, they found out she had a urinary infection and they were able to treat her. So I'm hoping that she'll be much better now. And besides medical illnesses, other causes, a very common cause of delirium is medications. So these are sort of the top 3 medications that are known offenders of making a person confused and delirious. Hypnotics like benzodiazepines, so these are your Ativans and Xanax. Opioid medications, OxyContin, Percocet, morphine, and also anticholinergic medications, medication that we use for urinary incontinence. And also you can get these, also a lot of people, they do buy Benadryl over the counter for sleep. And this is not the best idea because if they're sensitive to that, it's because it's a very anticholinergic medication. It can cause a lot of confusion, eventually leading to delirium. Okay, so let's talk about depression. Okay, so depression across the lifespan. So it does decrease with age. Depression, people tend to experience their first episode of depression, as a teenagers, through their 30s and 40s. However, as we get older, if you look at this graph here, so this graph is a percentage of people that are clinically depressed. And if we look at the left side of the screen, I would say, this what the study is showing that about almost 8% of the population at any time has some kind of significant depression. And it's usually predominantly female more than male. And if we break down the age groups, as you can see, older people don't have as high of a prevalence of depression as people that are younger. But however, the trend of female experiencing more likelihood of depression more than male is still holds. And other predictors would be people that are socially disadvantaged or having any psychosocial stressors that can also increase their risk for depression. So even though older people may not have as much incidence of depression, they actually, especially older males, are at very, very high risk for suicide. So these are the suicide rates that's broken down into gender, male versus female, and separated by age. So as you can see, what is a very consistent over the decades and a worrisome trend is that older male, especially we're looking at 75 years or older, have a highest rates of committing a successful suicide. So females are more likely to attempt, 3 times more likely than male, usually via overdose, but not as successfully. Whereas males, they're more likely to, 4 times more likely to use firearms and more likely to succeed. So what can we do? So what are some of the critical windows in which that an older male, is at the highest risk for a suicide? So this is usually, we often see that shortly after the dementia diagnosis. It's people know that there's no cure, it's horrible news, and it's insidious, meaning that you may be afflicted with this illness for years and there's nothing you can do about it. And you're looking at, possibly leaving your home, being institutionalized. And so this is sort of the critical period that we have to be sure that, offering all the support and monitoring as much as we can. And suicide rates are even higher with those with pre-existing mental illness. Okay. All right. So how do we detect depression in people that are older? So older people, especially people with dementia, they're not gonna tell you that, well, I'm depressed, I'm sad. But so what do we do? Well, there are other sort of telltale signs or more specific to depression in older people. Um, so one of the one of the most distinguishing features is that they're irritable. So if you have somebody that's been doing okay, but for the last couple of weeks or so, they're increasingly irritable, rejecting help, making little effort to engage, and you can see this in somebody whether they have dementia or not. Then you're probably looking at the possible onset of a depressive episode. And in other, also more specific features, not as specific as being irritable, for older people experiencing depression is that, they'll start having a lot of these, somatic complaints, like, feeling physically uncomfortable, more so than that could be explained by whatever medical illness they may have. Headaches, belly aches, low energy, um, and also they would start having reporting memory problems. And this doesn't mean that they have dementia or memory impairment. It just means that when a person is depressed, they do not pay attention as much. And the fact that they do not pay attention to what they hear or what they see, they seem to have memory problems. And this phenomenon is known as pseudo dementia. So a lot of times, if we treat the depression, we improve the attention, we improve their ability to sense the environment, thereby leading to a restoration or reversal, a reversal of their memory complaints. And also, they start having reporting a lot of difficulties with sleep. So this constellation of symptoms are usually would herald a depression that often have gone unnoticed and untreated. Okay, so how do we screen for depression in people that are older? So these are some of the more common instruments that I think most people or most caregivers or with some training could do. And the one I like to focus on is the geriatric depression scale, a GDS. It's a 15-item yes or no question, and I'll show you right here. So I think if you go to a lot, so the first one is PHQ-9. If you go to a lot of doctor's office, you may get a form like this, and then one of the staff may ask you about these questions. But this is more, it's not specific for people that are older, so I don't use it as much. So this is the one that I refer to, the geriatric depression scale. So these are 15 yes or no questions. All the bold answer, either no or yes, would denote 1 point. And the points, points are, five points or higher would suggest depression that may need further evaluation. So this is a pretty good tool just for a quick screening, except for, if you have somebody with a pretty moderate or severe dementia, they're not gonna understand these questions or be able to answer, answer them reliably. Okay. And for those of you that want to assess depression more objectively in dementia, there's a scale known as Cornell scale for depression dementia. Sometimes I use it, but most of the time we can just we can assess depression clinically. Okay. So what are some of the things that we could do as caregivers or family members to help those with depression, especially those people that are older? You do want to offer support, monitoring, call them, video visits, or visit in their house if safe. Trying to take them out if again if it's if COVID restrictions are complied with, um, and what's very important is you just want to be you want to do as much empathic listening as you can. I see you. Can you just share me what's going through your mind? Tell me how you're feeling. You want to avoid making any kind of pre-judgmental statements like I know how you feel. Once they hear that, they're just going to claim out. They're not going to talk anymore because they think you're a know-it-all, and then they just rather shut up themselves in this cocoon and not deal with you. And And then once you see these cardinal signs of depression, you do want to help them to get hold of the primary care physicians that may be able to help you with depression screening. Or I think most insurance now will allow people to access a behavioral health provider, either as therapists, or doctors, or psychiatrists, or even APRNs. And with COVID, a lot of them do offer online sessions. Suicidal thoughts, suicidal gestures. This is when you want to access emergency services, as noted here. Okay. And I put this slide up because I hear enough from people that, well, I'm depressed. There's no hope for me. I hear about all these horrible side effects and people not responding to medication treatment or their psychotherapy. Well, so one of the challenges of treating depression is to offer a hope. And I want to share them that there's always at least a 50% likelihood that the first medication you receive, or the first psychotherapy session you have with your new therapist, it's there's a 50% chance, or hopefully greater, that you'll get better in terms of response. Response means that you're 50% better than whatever original depression scores you had. And a combination of medication or psychotherapy, you can increase that success ratio to greater than 50%. And they may even tell you that, well, hey, my depression is one of those that's just very, very hard to treat. Well, we're not out of all options yet. There are other treatments like like electroconvulsive therapy, shock therapy, newer modalities, which is you wear this magnet helmet, and also ketamine that you have heard many times on the news now. They do offer even higher rates of success, and the time needed is even shorter. So, for example, ketamine, people can get better in a matter of weeks, just a few weeks, or even a few days. So I often like to go over this with them so that they have some realistic expectations and having some hope about getting better. Okay. All right, so let's go to the last D of geriatric psychiatry, which is dementia. Okay, so when we talk about dementia, we're looking at maybe the last stage of a memory decline. So in our lifespan, there are 4 stages that we all go through. So if we look at cognitive function, the higher the better as a function of time. So we start with just our normal cognitive function, progressing to what's known as age-associated memory impairment. And this is fine. This is normal. This is what I have. It just means that people my age, we just don't remember as much irrelevant information as people in their 20s and 30s. So if you give me a long list of random words or shopping lists, I won't be able to remember as many of them as people that are younger. But otherwise, I'm doing okay, and that's age-associated impairment. What we're more concerned about is when a person starts to progress into what's known as mild cognitive impairment and eventually dementia. So how do we, operationally define these 2 stages? So I'm going to go over that right now. Okay. So MCI, and I think the new term for MCI is minor neurocognitive disorder, but I still like the word MCI. It just implies a lot more. It's easy. It's just more easier to understand. So MCI. So it just means that you have some memory loss, you have some executive functioning problems. You're not able to plan as well. And if you took any kind of standardized testing, that means you're pretty much at the bottom 5th percentile, among your education and age-adjusted group. So this is not just having trouble remembering a lot of items on shopping lists. You're actually at the 5th, the bottom 5th percentile. So that's a cause of concern. So there's no loss of, however, unlike dementia, there's no loss of ADLs or activities of daily living. So what are ADLs? So this is a picture that shows different types of ADLs or activities of daily living, which can be broken down into instrumental ADLs. These are ADLs that require a little bit, more engagement physically and mentally. Things like doing your house chores, cooking, managing money, using telephone. So a person with MCI, even though they score poorly, they're able to still do all these. Um, and But why is it so important for us to identify that as a stage? Because 10 to 15% of people diagnosed with MCI per year will progress into dementia. So this is kind of like the very critical stage in trying to address all the reversible risk factors of cognitive decline as much as we can to prevent or to delay that progression into dementia. And later, we'll go over a short list of, what these reversible risk factors are for memory decline. So, what about dementia? So, dementia is very similar to MCI in terms of that they're also, having cognitive decline, memory loss. They also score horribly on any kind of standardized testing. And in addition, there's a loss of ADL. So they will start not able to do these activities, and eventually they will also lose, what I call more basic type of ADLs. They're not able to self-feed, not able to use the toilets, or to dress themselves. Okay, so if we talk about dementia, so I get a lot of questions about, what are some dementia types? What is more common? Is it even relevant for me to understand exactly what type of dementia, my family, my dad or my mom, may have? Well, the most common type of dementia is Alzheimer's dementia, which is, I would say that it comprises about 60 to 80% of all the dementias. So that is most common. And this is what you see typically, the gradual decline of memory. And then the second most common, which is still, I think, very, very under recognized, is what's known as Lewy body dementia. So this has a little different flavor from Alzheimer's. It seems to have, remember we talk about delirium where, it's like a roller coaster ride, from minute to minute. You could see that in Lewy body dementia, but the fluctuation it's a little bit longer. We're talking about maybe 1 or 2 episodes throughout a day, where there's a lot more visual hallucinations. You're having a lot more sleep problems. They talk and they act out in their sleep, and also they, eventually they have these Parkinson's-like features. Tremors. Your arms and your legs being stiff. So that's about, maybe up to 20%, if not higher, of all the dementias. And a lot of people will have a combination. So, for example, 10% may have both features of Alzheimer's and Lewy body. And then the third most common type is vascular dementia. This is usually as a result of having a stroke. And then we have other lesser less common types of dementia. One of them is frontotemporal dementia, where you may have heard that this is when dementia is characterized by people undergoing their personality changes, from somebody, from a very, very, like a goody two-shoe, well-respected person to somebody who has a lot of odd behaviors. So clinically, does it really make any difference, as the dementias progress in terms of treatment? Probably not, because, there's no cure, as I think it was one of the questions. There's no cure for any of these dementia. However, there are a lot of things that we could do to help to lessen the behavioral symptoms, to help to lessen the progression of memory decline. So there seems to be a convergence of we could do regardless of the dementia type to help to maintain their quality of life. And if we start looking at medications, I think, the reason, the type of medications used for behavior, they're all similar, maybe with one exception, that Lewy body dementia, a doctor may want to avoid antipsychotics because they're a lot more sensitive to it. Okay. All right, so I would say, for the rest of the talk today, we're just going to focus on findings and also the phenomenon of Alzheimer's dementia, because that is the most common. So Alzheimer's dementia, this is it's a dementia that increases with age in our population. So the rate of Alzheimer's doubles every 5 years, starting with age 60. So if I look at someone who if a population, they're 85 years or older, we're probably looking at a third of them would have Alzheimer's dementia. And I would say even maybe 45% of them would have dementia of all types. And this is a serious issue in the United States. I think, we're going to experience a doubling of people with Alzheimer's dementia. I think it's going to be the most expensive illness to treat. Within 30 years, going from 6 to 12 million people with this illness. Okay, so as a caregiver, how do you know that? Well, am I looking at an onset of dementia, or maybe somebody who is already progressing through, memory, mild cognitive impairment? Well, so if you remember the sort of the stagger 3D circles that I show you, that before you start wondering that, well, maybe I'm looking at dementia, you always want to do your due diligence, which is make sure they're not medically ill, they're not delirious, and they're not depressed, because these two things are easily, they're not easily, they're treatable, they're reversible. So, all right. And so now, when we look at memory decline, so there are two main characteristics of people that have that exhibit two main characteristics of people with dementia. So one of the main characteristics is that they're not able to retain any new information. So they will not, they won't be able to tell you what they ate, earlier, or with worse form. If you may have to repeat the same information to them many times, and they still will not be able to remember it. However, the same people could retain memories from way back. They could tell you birth dates of their family members, what reunion, what they did in high school, or family reunions from long ago. It does, so if somebody, when, so if you see that, I get a lot of family members telling me that, well, I don't think they have memory problems, because they know me, they know exactly where they live, they could recall their addresses, ever since they're, when they're little. Well, that's, with dementia, remote, what we call remote memories, there's the last to go. It is the inability to acquire new information. That is the hallmark of dementia. So, and also, if we remember, we talked about ADLs. Not only is there a decrement in memory, they're not also able to do their ADLs. So these are things that they could do before, they don't know how to do anymore, and it's not because of a physical disability. So frequent questions I have for your patients and their family members will be, are there things that you could do before that you couldn't do anymore? Examples would be not knowing how to use the remote anymore, not knowing how to pump the gas, or start getting confused about what keys go into what lock. So these are all some of the early signs of their ADLs are being affected. Also, not able to balance their checkbooks. That's also a very a telltale sign of a memory problem that is brewing and getting worse. Okay, so I'm just going to go over maybe a couple of simple instruments that caregivers could do without a lot of training to help to assess whether a person may have dementia or not. Because often the caregivers, the families that you live with person with memory decline every day, and you may not be able to pick out the subtle changes from day to day. Whereas if you do administer a more objective scale, it may help you to realize the extent of the decline. So a lot of you have heard about, MiniMental status exam, MiniMental, which is kind of copyrighted. Theoretically, you're supposed to pay, I think, like $1.50 to be able to use it. So what I have done a lot more in my practice, and which is supported by a lot of studies, is use an even more elegant or shorter instrument, and known as mini-cog, which anybody could do with almost no training. And I'm going to show you an example of that. And then, and for the later on, I'm going to show you a certain screening test that you could use for MCI or mild cognitive impairment detection. And what I prefer to use is SLUMS, St. Louis University Mental Status Exam. It's also public domain, anybody can use. You may have heard of MoCA, but this is something that I don't use anymore, especially I think they're starting to charge like $100 a year for you to be able to use it. Okay, so I'll just show you quickly what these testing instruments are. Okay, so this is mini-cog, and I think anybody can do this. Any caregiver can do it. It involves only two test items, which is a 3-word recall and a clock draw. So you ask them to remember 3 words, repeat 3 words. You ask them to draw a clock that shows 10 after 11. Afterwards, you ask them to recall to remember the 3 words. And this is sort of the decision tree here. If they're able to recall all the 3 words, you're probably not looking at dementia. But if they're not able to recall any, chances are good that they may have early dementia or worse. And what about if they can only remember 1 or 2 words out of 3, then you sort of use a clock as a tiebreaker. If the clock looks nice, got all the numbers, and the hands pointing the right numbers in terms of 11, 10 after 11, then they're probably not demented by the, but any clock less than that, you're probably looking at dementia. So how does this decision tree compares to primary care physicians? Well, there are studies showing that using this is actually more specific and more sensitive than primary care physicians of these people in detecting early dementia. And also people that don't speak English well or with lower educations, this test is also as effective, if not more, than the MiniMental. So this is something that I think a lot more you may want to consider using, especially if you suspect any kind of a cognitive decline. Okay. All right, so this is just example MiniMental. It's not as useful as the mini-cog, and as you can see, involves a lot more questions. Okay. And if you're really motivated, I actually have caregivers that actually try to do a SLUMS, St. Louis University Mental Status Exam. And the reason they wanted to do that, and you can actually download the step-by-step instructions and able to do it successfully. And as you can see, the questions here are much harder than the mini-cog. And the reason they're harder is that you want harder questions to detect somebody with a mild cognitive impairment. So this is sort of my go-to exam if I suspect somebody having a MCI rather than dementia. And that's why I went to medical school. So another reason for me to want to use it. Okay, and MoCA or Montreal Cognitive Assessment is very similar to SLUMS, but I think starting last year they're asking for like $100 or $200 for anybody to use it. And it takes longer, so I don't use this one as much. Okay. All right. So what are some of the things that we could do to slow down memory decline? So in terms of risk factors, there are risk factors that we can't do anything about, or irreversible. And these are, if you have a family history of dementia, there's a much higher chance that, you may be, that person may have dementia later. Age is also a risk factor. As you can see, the doubling of the Alzheimer population for, every 5 years, and also lower education levels. So we couldn't do much about that. But however, there are known reversible risk factors to slow down that memory decline. And one of which is anybody with depression is going to be at higher risk for cognitive decline. So even if you treat the depression, their memory will come back, but it's a lot of time it will not go back to that pre-depression baseline. So this is where aggressive treatment, aggressive recognition and treatment of depression will go a long way in arresting the memory decline. And also the what I call the three medical illnesses that are huge risk factors for memory loss are hypertension, high blood pressure, cholesterol, hyperlipidemia, and not controlling your diabetes well. And other things that I often counsel patients and their family members is to maintain your physical exercise, psychosocial routines, going to senior centers, reading, playing mahjong or chess, sudoku, and also having a diet, avoiding fat, increasing vegetable intake, fiber intake, all that can help a lot. And people are asking me about, well, what about memory medications like Aricept or Memenda or Memantine? Well, these memory medications can slow the decline by anywhere from, on average, 6 to 12 months. But the effect of slowing memory decline as a result of these memory medications are very small compared to doing all of these. So I always tell them, do not take comfort just because they are taking medical medications. That should not be a justification for you to ignore treating these reversal risk factors as much as you can. In fact, I would much rather a person have good blood pressure control, good cholesterol numbers, following closely with their PCP, than prescribing a dementia medication. Okay. All right, so I think that concludes the 3Ds of geriatric psychiatry. And just to summarize, kind of the obvious features of 3, just a review. Delirium is something that's acute, within days, acute change in symptoms, fluctuating attention, cognition. Depression is the classical, not concentrating, rejecting help, being irritable, loss of interest. So you should want to make sure that they're not undergoing any of these first. And then dementia is something that's more insidious, gradual, progressive, characterized by poor memory. But they're not irritable. They pay attention. It's just that they cannot retain the information. Okay. All right. So we're going to jump into the second part of my talk today, which is dementia-related behavior. Okay, starting with national and local crisis. Okay, so I think one of the main reasons we're all here today is is to deal with what's known about dementia-related behavior. And which is professionally termed behavioral and psychological symptoms of dementia. And this is very common, present in about, almost everybody with dementia would have experienced some form of behavior sometime throughout the course. And this is, usually one of the top reasons for institutionalization, why a person cannot stay at home, and also associated with higher mortality. And as importantly, it causes a great deal of suffering for patients and their caregivers, caregivers specifically. So we talked about, depression earlier, that, maybe 5 to 7% of people at any time in our general population would have depression. However, this risk is higher for people that are full-time caregivers to a little bit over 10%. What about caregivers for those, full-time caregivers for those with dementia? Well, this is some of the highest risk for depression that we're seeing. We're seeing about a third of full-time caregivers with dementia having to deal with depression. And we all know we all know that it is not a surprise that it is just such a trying, challenging, and often non-rewarding task to be able to provide for their everyday needs. Okay, all right. And not only so this is going to be a growing problem given the especially United States, given the baby boomer cohort becoming older and older. Starting about 2011, that's when the oldest baby boomers are becoming 65 years or older, and that we're going to see this gradual population upside down pyramid. That we're going to have more older people at the top for less younger people to support. Where do we see that? Well, one of the places we're going to see that probably ahead of everybody else in the United States is Hawaii. Why? Because in Hawaii, we have a very, very high percentage of people that are older or 65 years or older, 19% compared to 15% in the United States. And also, Hawaii has the longest life expectancy, 81 years old compared to 79. So in a way, we are sort of at the forefront here in Hawaii of embracing this huge need for geriatric mental health. Well, are we ready for that? Yeah, I'm just not so sure. What I've seen the last 10 or 20 years is that for outpatient services, we just don't have enough behavioral health providers, especially even fewer that would be agreeable to take seniors. And also, so therefore, there's the PCPs are having to do greater burden, shoulder greater burden of providing or educating the caregivers or prescribing medications as needed. And what about inpatient services? We're looking at patients that are severely depressed, severely psychotic, a lot of them with dementia. Where do they go if they're not able to be in a facility or with a family safely? Well, for a state with 1.4 million of population, we have zero geriatric psychiatry beds. And we're actually one of the very few states that do not have any dedicated inpatient geriatric psychiatry service. I train in New Mexico, and the state of New Mexico, it often can be a laughing stock. We always look at the rankings of poverty, healthcare. We just start from the bottom, and then we can always find New Mexico faster, than they're starting from the top. However, New Mexico, which has a population of almost 2 million, so like Hawaii, has 4 geriatric psychiatry inpatient hospitals compared to 0 in Hawaii. So what happens to seniors that need to be placed psychiatrically? They're sort of dispersed in various adult psychiatric units. They're already short in Hawaii, or they're stuck in general hospitals, and which is not ideal, because then you're not able to provide the level of non-pharmacological intervention as much as you can in these not so ideal setting. Okay, so given this lack of resources, what happens to these, so what do they do to access care? Well, they kind of, for our seniors, they start flocking to the emergency service. So we did a study starting about 2007. We're still collecting data right now. And there is a general trend of seniors going to the emergency room in higher numbers, in higher percentages compared to people that are younger, to a Queen Psychiatric ER, which is the only ER in the whole state of Hawaii that has 24/7 psychiatric presence or psychiatrist presence. Okay. And what is more alarming is, these seniors are getting, their behavior is getting worse, because more often than not over the years, they're being brought in by police. So this is when they're physically aggressive, the caregivers couldn't deal with them, they couldn't bring them to the hospital, they have to call the police for backup. So increasing from 12% in 2007 to doubling by 2011. And also because of lack of geriatric psychiatry beds, older people that couldn't be safely discharged back to their home or facility, they're stuck in the ER. So compared to all the other age groups, oldest patients, we're looking at people that are 80 years or older, had the longest stay in the ER. 8 hours is the average compared to, I think, 6 hours for people that are younger. And we have, a lot of times we have older people that are in the ER for 3 or 4 days, almost as boarding, because there's just no hospital that would take them, and the caregivers are unwilling to take them back. So they're sort of stuck in this, very, very chaotic environment in the ER, and that is just horrible for, for their mental health. So this is, this is one of the advocacy I've been doing is to help all of us to recognize the need for more and more outpatient and acute behavioral health services for our older population here in Hawaii. Okay. All right. So we're sort of going through the home stretch now. Let's go over the sort of the typical type of behavior that we may see in dementia. And this could be broken down into sort of these cluster. And the reason that they're broken down into clusters is each cluster can beget a specific treatment. So it would help the physicians to understand exactly what behavior they're looking at, so they're able to provide the specific treatment that would match one of these symptoms. So the list includes, psychosis, depression, apathy, sleep disturbances, agitation, and anxiety. And I'll go into each of these quickly. And the reason I have psychosis and depression in red is these are the two symptoms that, if not controlled well, will have a very high risk of ending up in physical aggression, and also hastening the progression of dementia. So these are the two symptoms that we do want to recognize quickly and treat. Okay, all right, so let's start with psychosis. So what does psychosis means? It's just, impaired reality testing, that their sense of reality is starting to be a little bit different from what we all consider as our reality. And what does that include? Well, they're able, that also, often it is just not recognizing where they are, not recognizing their caregivers, thinking they're intruders, strangers. They become paranoid, accusing people for poisoning them or stealing their money. And visual hallucinations, seeing, stalkers or strangers, more than auditory hallucinations, which we see more in schizophrenia. Well, how is that relevant? Well, psychosis in dementia is a well-known predictor of physical aggression, institutionalization, and higher risk of death. So this is something that we have to get a handle on as quickly as possible for the patients and also for the caregivers. Okay. Next one is depression. So depression in dementia is also very, very common, a little bit more common than the general population. 15 to 40% of Alzheimer's can have depression at any given time, especially in the earlier stages. If you recall that for older males, that their window of suicide usually when they're just, early dementia, being told about the diagnosis. And in people with Lewy body or Parkinson's disease dementia, there's a much, much higher risk for depression. So we usually like to screen and treat depression in this population aggressively. So unlike people without dementia that are older, telltale signs of depression is, again, they're irritable. It's because they don't necessarily will tell you that they're depressed or they're suicidal. Okay, so like psychosis, this is also a well-known risk factor. It's probably the #1 risk factor for physical aggression in dementia. Also associated with high risk of death and also faster memory decline. Okay, so agitation and disinhibition in dementia. This involves impulsive or inappropriate behavior, usually verbal aggression, screaming, and what we often see is in institutional, at nursing homes, include inappropriate sexual behavior, inappropriate propositions, or inappropriate touching. Apathy in dementia. This is when as the dementia progresses, they kind of become more sort of nonchalant, indifferent. They're lacking motivation. They don't eat as much. They don't do as much. They don't enjoy as much. But they're not bothered by it. They're not irritable like somebody with depression. So you do want to differentiate apathy from depression. So apathy, there's no poor mood. They're not lousy. They're not feeling grouchy, and you want to make sure that this is not. And you want to differentiate from depression, because if somebody's trying to treat apathy thinking this is, they're not doing as much, they must be depressed. And if you're trying to treat them with antidepressants, you can actually make the apathy worse. So I just want to make sure that I bring this point up because we do see enough people with apathy being treated with antidepressants, and they're not getting better. Okay, anxiety and dementia is very common, involving usually asking forthcoming events over and over again. Fear of being left alone, pacing, fidgeting. Okay, and in circadian rhythm disturbances with dementia, they sleep later, they have more broken sleep, there's sundowning. So we can go over some of the tips on how to manage that. Okay. All right, so now we have an overview of different types of behavior in dementia. So what are some of the things that we could do as caregivers and providers? So we're gonna start with non-medication approaches. So, part of the easiest thing is, when they're agitated, let's figure out exactly whether, it could be their diaper is wet, or they're hungry or they're in pain. So if you're trying to figure out exactly what they need, address it. Usually that will go a long way in decreasing the behavior. But other, more general tips of dementia care is you do want to speak calmly, with gentle touches, provide some kind of sensory stimulation. Using gestures, if they're able to read but not able to hear, you can write down simple questions on a large screen, which is what I do. I carry a small laptop with me, and I would just type in the words, and they would easily see that. And also, which is very important, when you provide care, you want to approach the patient from the front. If you're going to feed them, make sure they see you in front of you. Make sure they see you in front of them, holding forks, not, and the food. If you're going to change, change their diapers, make sure you hold the diaper in front of them so they know exactly what you're about to do. Because the last thing they want to do is, given their hearing and sensory and visual impairment, they do not like to be surprised. Because when they're surprised, that's when they'll lash out and often becoming physically aggressive. Okay, and conceal exits. Especially people that that may elope. This is actually an exit, but it's sort of camouflaged by these plants. So there's one example. Make sure they're occupied throughout the day with different tasks. So sensory stimulation. So there's a lot of studies and talks about, what are some of the best ways to provide sensory stimulation, because they're sensory deprived throughout the day. They're going to find their own ways to get that, extra sensory stimulation or the sensory stimulation they need, often inappropriately. So what is much better is to just provide that low level or as much as they could tolerate. So people use plants, animals, massage, aromatherapy, and music. And I would, here I do want to make a plug for music. Of all these sensory modalities, music has been shown to be the most effective in decreasing agitation, overall agitation in people with dementia. And when we talk about music, we want to look, we're referring to music that is familiar to the patient. So usually what, music that they listen to in their, teens or their 20s. Okay. And okay. So, and this slide just shows you that, even though, these non-pharmaceutical, interventions, massage, aromatherapy, different things, they can only do so much in terms of decreasing agitation, because it's still not well known if they're effective long-term. And study has shown that of all the types of non-pharmacological therapies, only music so far has been shown to be consistent in decreasing the level of behavior. But we should try that, even though there's not too much evidence to support it yet, because they do not have a lot of side effects, unlike medications. Okay. And then, so non-medication approaches, for people that are paranoid, hallucinate, I recommend go with the flow, avoid confrontation, don't try to rationalize them, don't try to tell them they're wrong. It's just going to make them so much upset, a lot more upset. Um, okay, and sleep. So a frequent complaint is, somebody who stay up all night, driving the caregivers, nuts. Caregiver cannot sleep because they're afraid that they may fall or they will elope. So I would say the easiest way is to make sure that people with sleep problems, not able to sleep at night, make sure they wake up wake up at the same time in the morning and avoid long naps. Because if you keep them occupied throughout the day, their body's going to be tired. It's going to be more likely for them to go to bed. And this is a much better and safer way to address lack of sleep at night versus using sleep medications. Okay, and activities are always good, especially individualized activities or day programs. And this is a senior handbook that I do want to bring to your attention. Attention that has a very nice list of different day treatment programs for seniors and also different services for the caregivers to access. Okay, all right. So I think we're toward the very, very end of my talk. The role medications. I'm not going to talk a lot about this today because this is not a focus on what medications to pick. This is more for when caregivers and family recognize medication will be needed. So why do we use? So before we consider medications, again, you want to make sure they're not medically ill, they're not depressed, and also they're not constipated. That's another cause for physical aggression in dementia, and also pain. Okay. So when will medications be appropriate? This is when a person has severe depression or very distressing levels of psychosis. You have imminent safety concerns, and you want to use a medication to avoid being placed or having to go to emergency room. And for the whole point of, there's no cure, as we talked about. The whole point of the medication is to maintain the highest quality of life as much as possible. And this is sort of illustrated right here. So if we look at the correlation between quality of life and dementia, dementia's symptom severity. So as the symptoms become more severe, there's a decreased quality of life. And with non-medication approaches, we can help to maintain that quality of life. After which, it would still, go down due to the severity of the symptoms. And this is when medication use could be appropriate. So if we use appropriate medications, that will help to maintain that quality of life, whereas inappropriate use would actually make it a lot worse. Okay, so now we're just going to take a break and switch gears and go over the pre-webinar survey questions one at a time. So the first question is, there's no cure for dementia, but it is possible to try to slow down the progression of the illness or to lessen behavioral symptoms of this illness. So the answer is true, because this is what we've been talking about for the last hour or so, about all the modifiable ways we could to lessen impacts of this illness. Okay, so next question. Once a person with dementia is placed in a facility with caregivers experienced in dementia care, they should be able to manage all types of dementia-related behavior, including physical aggression, without any need for medications. So, while this may be the case, for a lot of behaviors, but when we start looking at safety issues, aggression, this is when medications will be indicated to help to maintain that quality of life, as well as to ensure safety for everybody. So the answer for this question will be false. Okay, so next question. If an older person with dementia gradually becomes more irritable, increasingly refusing food and care, it could be a sign of depression. Well, the answer is true. This is what we had talked about, that the telltale signs of a person with depression, older, and maybe cognitively impaired population is that they get, grouchy, they get more irritable than ever, refusing help. So the answer for this question would be true. Okay, so let's go to, I've got two more. Next question. If somebody can still recall details and birth dates of family members from long ago, this person is unlikely to have dementia, even if the person is easily confused in new situations and unable to remember new information. Okay, so as we had talked about earlier, even if a person can remember things a long time ago, which is what we call remote memory, what's going to be affected in dementia is the more recent memory. So we pay more attention to how they're able to retain new information. And as dementia progresses, the person will start losing older information, so that in advanced dementia, the person may even have trouble recalling, what they did for work or where they went to high school. So the answer to this question would be false. Okay, so last question. Um, a person with dementia angrily accuses a family member for stealing, despite repeated denials by the family. The next best thing to do is to ask the doctor to side with the family to tell the person that the allegation was untrue. Well, this is not effective for a couple reasons. The first is, even if the doctor, even if the patient agrees with the doctor that, well, maybe these accusations are unfounded, that person is more likely to just remember, whatever he or she hears at the doctor's office. Um, and and the way to address, these paranoid delusions by the caregivers is to try to find ways to redirect, or distract the patient versus rationalizing with the patient, because they're just going to get more agitated. Um, so, recently we, at a care home, we had, a person with dementia chasing a staff, thinking that the staff has stolen, I think, $20 from the patient, and that was going on for weeks. So what we decided to do was just have the staff return the $20 bill, just produce a $20 bill and return it to the patient, and she was happy. And then a few minutes later, she forked over the $20 bill to the social worker for safekeeping. And that took care of it. So the patient never made another accusation toward that same person. So this is an example of just kind of going with the flow, start thinking on your feet, always, versus trying to be confrontational, which is just not going to be very effective. Okay, so we're going to go back to the last part of the talk. So the answer is false. All right, so we talked about types of dementia related behavior, non-pharmacological interventions, as well as indications for medications. So if the caregivers feel like maybe the medication should be considered, that would mean that, well, let's go to the doctor's office, a provider's office, to see what could be done. And this is when it will be very, very pertinent for the caregiver to be sort of armed with sufficient information so the doctor can make the best informed choice, deciding whether medication is needed, and if needed, exactly what medication it would be. Okay, so the most important thing is, please bring a complete medication and even supplement list, whatever supplements they may be taking. And this will help the doctors to identify a medication that could be, counteracting one another, or medication that could be leading to confusion, or medication that may underlie some of the behavioral symptoms. For example, those, sedating or anticholinergic medications. And also, it would help a lot to, instead of saying that, well, this person's agitated without specific details, if the caregiver can describe, clearly what are the triggers, what did the patient do, and what the caregivers did to in response, whether it worked effectively or not, and as well as how these behaviors had could be dangerous or led to very worrisome situations, or just leading to imminent caregiver burnout. So all this information can help the provider to decide to what extent medications can be considered. Okay, so, and say if the medication is only on the docket to be tried. You'll probably know already that there's no such thing yet as a FDA-approved medication for dementia-related behavior. So there are a lot of medication that have been shown to be effective and safe if monitored closely. They just haven't had the FDA approval label yet. It doesn't mean that we're not going to use them, because they actually can be very helpful. But for the protection of the patients, it is prudent for family members or caregivers or surrogates to be involved, so they're able to make an informed consent regarding understanding the benefits and the risks of these medication trials. Okay. So in general, I don't want to go into the specifics of the medications that could be done. I do that for for different different talks specifically for providers. But in general, antidepressants are something that we like to consider first. It can help with not just depression. It can help with agitation, psychosis, and they have less side effects compared to antipsychotics. So antipsychotics, for example, would be risperidone, olanzapine, quetiapine, or even Haldol in the older days. They're stronger, but they also have more side effects. And then sometimes people ask me about what about the typical dementia medications like donepezil, which is Aricept, or Memantine, or commercially known as Namenda. Well, these medications, they don't have a lot of side effects. If they have side effects, then we just discontinue them. They can help to slow down the memory decline by anywhere from a few months up to a year. After that, the decline will still continue. So there's nothing that it could do, these medications could do to reverse the memory loss. And not only does it help to slow it down by an average of 6 months, these dementia medications can help to have some small effects in decreasing the overall agitation and depression, or even aggression, but not as effectively as antidepressants or antipsychotics. And this is the last thing I want to cover in terms of evaluating the effectiveness of medications. When we choose medications for dementia-related behavior, we want to use medication that has the highest potential for benefit and the lowest risk. Also known as ones with the highest benefit versus risk ratio. So if I sort of array the typical medication groups on this graph right here, with the x-axis denoting more higher benefit as we move to the right side, and then the y-axis with higher risks as we go up. As you can see, which I talked about earlier, that antipsychotics like risperidone, they can be very, very effective in decreasing the aggression, the psychosis, and dementia, but it also has a lot of, confers a lot of risks. Therefore, we would prefer to use antidepressants or prazosin as first line, because they're almost as effective as antipsychotics, but the side effects are much more manageable. And this is an example that I want to share with you. On the other hand, benzodiazepines, this is Ativan or Xanax or Valium that you may have heard. They're not very effective because they have low benefit. They just get sedated versus any sustained decrease in agitation. And in addition, benzodiazepines have a lot of risks: confusion, sedation, and increased falls. So this is a group of medication that we tend to avoid. So again, even if there's no FDA approved medication for dementia-related behavior, that there's enough science, enough studies out there for us to make an informed decision about medications in terms of their benefit versus risk ratio. So we're able to choose as appropriately or as wisely as we can. Okay, and I'm just going to use one specific example to illustrate what I mean by benefit versus risk ratio. And using this very, very common medication used for dementia-related behavior, which is risperidone. And risperidone, like all the other antipsychotics, it has it has a notoriety of being having this black box label by the FDA because the antipsychotics. So what does the black box label says? What does it say? So it says that medications like risperidone has increased mortality in older patients with dementia-related psychosis. So maybe we should have second thoughts about using it. Okay, so let's evaluate the benefits and then we'll look at the risks. So what are the benefits? So in my experience, which is consistent with other studies, when we use very low doses of risperidone, specifically for physical aggression in dementia, yeah, I'm very comfortable telling the family members that there's about 30 or 70% likelihood that all these dangerous situations, the physical aggression will go away or will be much reduced. What is the risk in terms of the black box label? Well, the study showed that the risk of death probably would increase from 3 to 4%, or maybe 5% according to some studies. So you're looking at maybe 50% chance of the quality of life being much improved at the risk of maybe 1 or 2% of increased risk of death. And this is the information I think I'm obligated to discuss with the family members so they can make an informed consent about whether they want to consider such treatment. Okay, and even if they decide to have the medication trial with antipsychotics with the black box label, we have to consider tapering and decreasing once every few months, once every 6 months or so, because studies do show that psychosis or delusions or aggression in dementia, they're not long lasting. They usually don't go on forever. They usually come in cycles of anywhere from a few months to almost a year. So which means that if they're doing okay, on antipsychotic, for example, it's been 6 months to a year now and they're stable, then yeah, it probably will be a good time to consider a gradual reduction of these medications because the less, the better in terms of minimizing any long-term side effects. Okay, so and this is just going to give the audience some idea about how we in the University of Hawaii with all my colleagues doing a geriatric psychiatry care, had tried to make an algorithm to help the primary care physicians to kind of couple specific symptom clusters of dementia to sort of this evidence-based medication choice from what is considered first line in terms of higher benefit versus risk ratio to ones that have lower benefit versus risk ratio. So for example, going back to hallucinations and paranoia, we probably would consider the antidepressants first because they're safer and they're almost as effective as the antipsychotics. And only if the antidepressants don't work do we resort to the higher risk type of medications such as antipsychotics. Okay, so we're not going to talk about choosing medications anymore. Say, once the medication is chosen, so what should the caregivers expect in terms of how effective it is and if there are any side effects? So providers should, in general, start with a low dose just to make sure that they're, the patients are able to tolerate it. And at any dose, if it's going to be, even if it's going to be effective dose, it may take up to 2 to 6 weeks, for any kind of sustained improvement to be realized. And during this time, if the caregivers are still seeing the same behavior, it doesn't necessarily mean that the medications are not working. It just means that it needs more time, or maybe that the doses are just not high enough. And also, if the behaviors are not improving, it doesn't mean that the behavior is a direct effect of the medication side effects, because this is the same behavior they're being seen, even before the medications were started. However, you do have to be, vigilant for any quote unquote real substantiated medication side effects, and which is usually uh, specific to sort of new symptoms that are clearly different from the behavioral baseline before the medication. So for example, if if the person has the same level of agitation, but then within a week of starting a new medication, then all of a sudden this person is very, very drowsy, started to fall, not able to sleep, gets easily confused or much more constipated than ever, then these are signs that it's very clear from their pre-medication baseline. We're probably looking at some side effects of these medications, and this is when the provider should be contacted as early as possible to either lower the dose or try something else. Okay, I think this is my last slide now. So I mean, there is empirical evidence to show that for again, antipsychotics, when antipsychotics are used at low doses and used responsibly for very specific symptoms, which is aggression, they don't lead to any higher rates of death or institutionalization, among as consistent with the study that looked at dementia and respiratory and dementia and antipsychotic use in a community population. So in fact, these people that receive antipsychotics for aggression or agitation, and I think if I remember the study, they actually have a lower rate of death compared to those people who didn't get that with the same symptoms. So this, again, is consistent with what we had talked about earlier in the talk, which is that it is the untreated, debilitating levels of depression, psychosis, physical aggression, those are the worst culprits in terms of accelerating memory decline, physical decline, poorer quality of life, and institutionalization. So these are the things that it will be prudent to really seriously consider the role of medication for these kind of severe behaviors. Okay, so I want to thank you for everybody for being here and showing interest about this emerging problem that's going to take more and more resources and more of us to acknowledge and find expedient ways to try to tackle and manage. And I also want to thank all my colleagues at University of Hawaii, Queens Hospital, and all the patients and the caregivers and the family that had taught me so much over the years about how to help, how to give help back effectively. And also this is the sponsor for today's talk. Okay, thank you.